being present is key to any patient in general, but especially when you're a victim of trafficking, whether it's labor or sex trafficking or domestic violence, like sexual assault. These are psychological traumas, and to be trauma informed, you have to understand that if they're looking away when you're trying to make eye contact with them, I mean, that could be red flag. They're looking away or always looking at somebody else in the room, making eye contact with somebody else. Well, first question, why is there somebody else in the room?
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement because we all know emergency nurses have the best stories. Now, here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here, and welcome back to the Art of Emergency Nursing. As always, I appreciate you listening to the podcast. Don't forget to share this podcast with people you like, people you don't like. Every nurse you know needs to hear this podcast. And as always, I'll ask you that if you have a few minutes, if you can leave a rating and review in your podcast player of choice, that goes a really long way to helping other people discover the show. All right. My guest this week has an amazing story to share. Not only is this guest an emergency nurse, but she's also a certified SANE nurse for both adult and pediatrics. She works with healthcare systems and law enforcement agencies worldwide combating human trafficking and commercial sexual exploitation. She has taken the stand in courtrooms as an expert witness for sexual assault, human trafficking, and strangulation. Few nurses have had the impact that this guest today has had. In today's podcast, she's going to share with you her story from an exploited teen to the resilient hero she is today. This story is going to blow your mind. Buckle up, get ready, and welcome to the podcast, my friend Rachel. So what I like to always just start with is just introduce yourself. Tell the audience who you are, what you do, how long you've been a nurse, and that kind of thing.
My name is Rachel. I've been a nurse for almost 10 years. I started in Detroit, Michigan, and came down to Houston, Texas about 5 years ago. And I currently still work in the ER, and I also do forensic nursing. I've been in community-based forensics as well as ER-based, so I've done them both. And here in Houston, I've done both as well. And I also do legal nurse consulting and testify in state and federal courts on behalf of patients, whether I've seen them or just as an expert for various attorneys. And then I do a lot of trainings at major conferences on nursing, forensics, strangulation, human trafficking, and all that fun stuff.
Holy cow! Lots of expertise there. Holy cow! What made you decide to become a nurse?
What made me decide to become a nurse? I'd always wanted to do something in the mission field. Mission work, whether it was be a missionary. And so growing up in the church, I always wanted to do something that was giving back. And then as I got older, I wanted to do something that was missional, but also that I could travel and do in various areas, whether it was out of the country or just very versatile. And nursing was something that you're caring for people, so you have that aspect. And so it's missional and you could travel with it. So I wanted to do travel nursing. So going into it, I wanted to specialize in emergency because I like the trauma and all the stuff you see on TV. So I liked emergency. So the first job I ever had was in the ER.
Okay.
And then even going into that one, I show up in the ER with my resume, and I hadn't even graduated nursing school yet, didn't even sign up for the NCLEX. Handed the manager of the ER my resume, and he's like, so you haven't finished nursing school. You're coming to a level 2 trauma center and you want to do this right out of nursing school. What makes you think that you're qualified? And I was like, I don't want any job. I want this job. And he's like, all right, we'll set up an appointment next week. It just happened, and it was awesome. And then finishing out nursing school, I heard about forensic nursing, and the other passion that I had was law. So my brother had always told me he wanted me to be a lawyer to get him out of trouble. And so law was always another angle. And so with forensic nursing, it's the area of nursing where the health and legal systems intersect. So that was an area that I could do both the legal side and be in the courtroom as well as be as a bedside nurse. So I got to do the best of both worlds.
Very cool. Very cool. And at what point in your nursing career were you sure you made the right choice?
I was sure I made the right choice when I realized that I wasn't working. when I would go to work, and I enjoyed it, and I looked forward to
Oh,
going back to work. And
isn't that nice?
it is nice, especially the ER. It's different. It's a different group of people.
Oh my
Just
gosh.
the camaraderie, the things you have to deal with, and the level of trauma, and just things that you see, you bond on a different level, even with the doctors. And I mean, there were times I'd work 7 days straight just because I loved working. Um, and even though they're 12-hour shifts, I'd still pick up 16-hour shifts, and I was just a
Oh my
workaholic, but I
gosh.
just loved it.
That's super cool. Yeah, it's one of the things I found when I went to the emergency department, when I first got to the emergency department. I remember being there being like, okay, this is what I'm supposed to be doing. Like this is it. Like, cuz it's easy to go to work. And that's kind of nice. It's kind of nice, I know I have friends who aren't in nursing that they're like, oh, regardless how easy their job is, they're just like, oh God, I gotta get up and go to work tomorrow. And I'm like, I gotta go to work too. It's gonna be fine.
Hmm.
Like, it'll be a good day. I'm like, oh, it's Monday. It's going to be a shit show. It's going to be great. That's going to be awesome. So it makes it easy to go to work, and then makes it easy to then, be there and do it for 12 hours at a time.
Yeah.
So that's cool. Tell me about a patient that changed the way you practice.
A patient that changed the way I practice. Ooh, I mean, we've got the sad stories, we've got the exciting stories. Probably it would be the first patient that I lost.
Oof.
So it was right after I was actually still on orientation. I still had a preceptor, and she was letting me take care of a patient, and it was a psych patient with chest pain, but also police prisoner. So handcuffed and with an officer. And I'm a new nurse. I've got my preceptor, and she let me go into the room and take care of him because there was an officer there. And I remember he had to go to the bathroom, and the officer walked with us to the bathroom. I was like, oh yeah, you could just leave him. He's just gonna go to the bathroom. I'll be here. He's like, are you sure? I'm like, yeah, uncuff him, the poor guy, because I had talked to the patient. And I felt bad for him. He was all cuffed, and he was really nice to me. I felt bad. He was showing me, his wrists that were like blistering, and the cop just seemed to not care. So I felt bad for the guy. So I wanted him uncuffed for a while. So the officer let him go to the bathroom, and I was standing outside the door, and then my preceptor had called me over. So I went over, and I was talking to my preceptor, and then a few minutes later, the cop is banging on the door, and he's like, why isn't he answering the door? I'm like, he's probably needs some privacy. He's like, it's been over 5 minutes. I was like, oh, how long was I talking to my preceptor? And she's like, well, didn't the cop go in there with him? I was like, no, the officer, I sent him back to the room. She's like, you did what? So we ended up getting the charge nurse, getting security. They had to manually open the door, and the patient was gone.
Holy shit.
Literally gone. And I looked up into the ceiling. He had crawled under the toilet, moved the tile in the cieling, and he had gotten into the ceiling of the hospital. So they had to shut down the whole hospital. And we were literally walking around the unit, and we were looking at the ceiling to see where he was moving to.
Oh my gosh.
So we definitely lost him that day.
How funny.
But I definitely learned that no matter how bad you feel for a patient, especially if it's a police prisoner, they're in cuffs for a reason. It's still protocol. So I learned to never breach protocol, and to never think that feeling sorry for somebody would be the best health choice to give them.
How funny is that?
First patient
my
I
gosh.
lost. The officer ended up losing his job on his end.
Holy
I
cow.
felt bad about that because he should have stayed with the prisoner, but I made him feel so confident that he could leave him with me, and then I left the patient.
We had a patient once who it made national news. We had a patient who was a police patient. He was there in the emergency department. He was in this room, and the cop was literally sitting outside the door. And he was in this like big room that they didn't clear in any way. And yeah, they were. I think he was supposed to be handcuffed to the bed, but apparently he wasn't, because he ended up getting up. He got up. He found a gown, gloves, mask, hat, the whole shebang. He put them all on and literally opened the door and walked past the officer. And the officer seen this happen, didn't think anything of it, was like, oh. And then sure enough, the officer goes in the room, and there's like some blankets underneath just like a kid would do, some blankets underneath the blanket, and the guy was gone. And the officer's like, well, it must have been someone's fault. And he, had lots of people to blame, like lots of reasons why it wasn't his fault. And he was distracted. And the person, somebody who went in must have let him out. And then we watched the video because it was all captured on video, and there was absolutely nobody in the room. The officer was sitting there in front of the door on his phone, and the guy just walked out, looked at the officer, walked out. You see him walking down the hall in the emergency department, takes off the gown, gloves, throws it all away, and runs out the door. And we were like,
wow.
Nobody thought anything of it. Like nobody's seen that piece. And sure enough, he got back. Like they ended up arresting him again a couple of days later, and he ended up coming back to the emergency department because he still had a super infected hand. But oh my gosh, and that cost that officer his job. Like that officer lost his job, and rightfully so, because he truly wasn't watching the guy. But it was like, oh my God, when I heard about it, I was like, that's the funniest thing I've ever heard. Like he just put the gown on, just walked out. I'm like, why wasn't he handcuffed? And like, I don't know. So, like, that's too funny. Holy cow. I was expecting you were going to say the guy like hung himself or like overdosed in the bathroom or something. Oh my gosh.
Yeah. The fact that we can laugh about that is horrible.
Right. Yeah, that does make me a
I was
horrible
hoping
person.
he overdosed.
No, I didn't say that. No, come on now. Don't put words in my mouth. But that's what I was expecting you were going to say. So, I mean, I got that story too, So tell me about the first medication error you ever made.
First medication error. Ooh. It's an error. So Phenergan, I remember there was a trauma patient that came in, and she wasn't walkie-talkie, by times 3, she wasn't walking at all, but she needed to go into emergency surgery, and we were waiting on the surgeon to come consent her. And I gave her morphine and Phenergan. And the Phenergan, you're supposed to push over a couple minutes. And so I gave her the morphine, and she's screaming in pain. And she's like, when's the surgeon going to come? And she's got her femurs hanging out. Ortho's in and out of the room. And like, okay, he's coming. And so I give her morphine. I'm like, okay, just it'll kick in. You're going to feel really warm. And then I get the Phenergan. She's like, morphine makes me nauseous. I need something. I'm like, okay, I got the Phenergan. And I pushed it in really quick. The surgeon walks in the room. He's like, all right, I got the consent forms. Push it in. And all of a sudden, like her heart rate drops down to like 50. And she like just goes like this. And he's like, what'd you just give her? And I'm like, morphine, 8 milligrams. You said to double it. And he's like, what else? I was like, Phenergan? I was like, she's in a lot of pain. This is like when I was first starting at 11 Trauma Center. I was like, oh, it's what you're supposed to do for trauma. Give him pain meds fast. But she was fully talking and screaming, and she's like, when is he coming? As soon as he comes in, she just literally was just like, boom. And I was like, okay, she's got a pulse, she's breathing. But she was not very arousable. And the surgeon was so mad. He's like, I got to go to the OR. Everybody's prepped. I was like, well, it's an emergency. Can't you just take her? And he's like, she was fully able to consent, and the family members wait. I'm like, oh my God, I can't believe I just did that. And so the charge nurse came because the surgeon was like making a big scene. He's like, what, does she not know how to give medication? And the nurse was like, well, what did you give? And she's like, so did you push it slowly? And were you talking to see a response before you gave them? Or you just gave them back to back? And I was like, yeah. Just sounded like a good idea at the time. I think it was like 12.5. Maybe it was 25. Yeah, it was definitely 25.
Snowed.
I was like, maybe if I give a full 25, it'll be better.
Oh my gosh.
No, nursing doses is not good. That was a really bad new nurse mistake.
Not for somebody waiting to consent.
Yeah, not for somebody waiting to consent. That was really bad. And it was like right as I pushed the Phenergan.
Holy cow.
Yeah.
Holy cow.
New nurse mistakes.
Yep. I'm sure that's true. Holy cow. Tell me about a patient that touched your heart, a patient that you'll never forget.
Patient that touched my heart. So it was a teenage patient, and this was a runaway, and she was in this foster care system. And this was my 3rd time seeing the same patient, and I did a rape kit every time because I got called into the ER for whenever a sexual assault comes to the ER, they page out forensics. And so I showed up, third time seeing the same girl. And so I remember sitting down talking to her. I'm like, hey, listen, it's like, what is going on here? Like, what's the deal? Like and she's like, well, I don't have a family, and I'm in the foster care system. I've been in 8 homes, and CPS, the state, they pick me up and they bring me right back, or they'll put me in at Chimney Rock, or they'll put me somewhere and they just bring me right back in the same situation. And I'm like, so, but you're out there and you're working for a pimp. Like, why is that? Why is that better? Like, what are you running to? I mean, are you running from something or to something? Because the stories you're giving me are pretty terrible, and I get the life. So why do you keep going back? And she's like, well, if you get the life, then you get where, like, how bad it could be where I'm coming from if that's what I'm running to. And she's like, the state keeps picking me up and putting me right back in the system. And I was like, okay, yeah. So that really made me stop. And I mean, she was a young teenage girl. She was 13,
Oh,
but she had run away 8 times, and she just kept going back to her pimp every time. And that really just made me stop and think, like, she sometimes, I mean, our system is broken. We know that. And I've done education to DFPS as well as law enforcement on training and forensics, and the need to bring the child to the ER for proper care and a medical forensic exam. But it really just hit me, like, they're not always running to something. It's not that the pimp in the life of human trafficking is so great, they're running to that. Sometimes these kids are running from something. In many of the cases, they're running from something. So if you pick them up and you rescue them and you save the day, you're putting them right back into the same home that they ran from for reasons.
yeah.
And and that's what she said. She's like, I made $4,000 yesterday. What did you make? And I was like, well, I didn't have to be with 10 men to do so, and you ran to that. You chose that this time. She's like, did I really choose it? Because would I rather have my mom's boyfriend do that to me, or am I going to go and I'm going to actually get paid for it?
Ah,
And so that conversation, like, really hit me at a different level. If I made $4,000 yesterday, what did you make? And to her, I mean, as a young girl, she wants all the fancy things, and to her that made more sense to be taken care of by somebody who's groomed her and is pimping her out than to be at home with a stepdad who torments you.
holy cow. What a terrible, there's no good choice.
There's no good choice.
There's no good
so
choice.
Then at the end of the day, was it really a choice?
Yeah, that's a good question. That's a real fair question. Let's talk a little bit about your forensic experience. What made you decide to get into forensics?
So into forensics. So I was born into a family where my father was leader of a biker gang, and my brother was into gang activity, and my mom's been in prison my whole life. And so I was actually in the foster care system myself.
Wow.
And so my brother and father, I mean, obviously they're not the best law-abiding citizens. So they had always told me that they wanted me to be a lawyer and go to law school, so that when they get in trouble, I could be their criminal defense attorney. And so it was always a joke, but it was always something that they wanted me to do. And my brother was murdered by a rival gang when I was 13 years old.
Oh my gosh.
And he was 20 at the time. And so he was kind of my protector during all of that. So when I went to nursing, it met all the things that I wanted to do, but the forensic aspect of it filled that gap of being able to be in the courtroom, being able to advocate. And I do work for criminal defense attorneys as well as prosecutors and civil attorneys. So I get to do a little bit of both. I can use my medical knowledge in the courtroom to explain to a reasonably prudent person the medical aspects that they don't understand, to be able to try a case effectively. Whereas an attorney or a judge or a jury can't do that without that medical expertise brought in. So forensic nursing was a way to be able to do that, and then to be able to do the forensic exams. For me, my motto has always been from the street for the street. With my background and everything I grew up in, I never had a forensic exam. I never had anybody take care of me when I was a cry for help, because I wasn't really crying about it or talking. I just was hoping somebody would see me, and nobody ever did. So being a forensic nurse, you get to, and I say you hear and see the worst cases. It's like CSI on steroids in the ER.
Like, and I think of how tough ER nurses are, and I think it's a fraction of what forensics goes through. It's a fraction.
Yeah, and it's still trauma, whether it's psychological, sexual, physical. Trauma's trauma,
Yeah.
and just the stories that you hear. But to be able to be that light in the darkness, because I'm a pediatric specialist, I do adults. I'm certified adults and pediatrics, but I specialize in pediatrics, and
Wow.
that's my favorite population to work with, especially the little kiddos. They're 5 and they don't know what they're explaining to you, what that actually means, and when you hear it come out of their mouth, they're like, there's no way that a 3-year-old could even know how to formulate those words and put them together. So this is a problem.
Yeah.
But yeah, so to be able to be that light in the darkness for children in the forensic aspect, and to be able to educate people in the courtroom was key.
Wow. Before I became a nurse, I did a little bit of time as a psych tech. I worked in a psychiatric facility, and the facility had 2 campuses. They had an adolescent campus, and then they had a geriatric campus. It was geriatrics, and it was sex offenders, and it was teen sex offenders. So we had 2 different campuses, and I worked on the adolescent side, and for the adolescent side, I'll never forget. One of the things I learned is I realized how damaged some of these folks were. Some of these kids were, oh my God, like you'd read their histories and you'd just be like, oh my gosh, this kid has been through so much. And, we had kids as young as 10. We had kids as young as 5. We had a 5-year-old there for a while that I was like going, how do you put a 5-year-old in a mental institution? But they had to, because he was constantly trying to hurt himself and he didn't know what he was doing. He didn't know that he was going to kill himself, but he was like, he would try to kill himself. And you're like going, how damaged are you? And then you realize everything that this child's been through at this young age. And you're like going, do you even have a chance? And we had one night that changed my career trajectory in a lot of ways. I was doing behavioral health and I was kind of digging it. I liked who I was working with. I liked what I was doing. And I was actually getting ready to switch from the ER to that full time, because I was working in the ER as a tech, and I was getting ready to switch full time to the behavioral health. And one night we're there, and I worked the evening shift, like 3 to midnight or whatever, and we hear this tapping on the doors, and we're like, who's tapping at the door? And this hospital was in the middle of a really bad neighborhood, and so we're looking out there and we're trying to see who's tapping at the door, and it goes from one door to the next to the next. And then finally we realized that it was one of the former residents who was tapping on the doors, and we're like going, and this girl shows up and her name was Maria, and I'll never forget Maria because she changed the way I look at patients. Maria comes in and she's beat to hell. And I was like, oh my God, what happened to you? And she's like, it's been a really long week. I've been tied up and being sexually abused for the last few days. And I was just like going, holy cow, what are you doing here? Like, what are you doing here at midnight? And she's like, I didn't know where else to go. She's like, this is the safest I've ever been. And I just remember that just knocking the wind right out of me going, this is the safest she's ever been. This was the place she considered safe. And I'm like going, a mental institution. And you're like going, holy cow. So we ended up, myself and my boss, I ended up calling my boss in the middle of the night. We ended up going down and getting her a SANE exam. And I remember going down there and doing that with her and talking to her through it, and talking to the SANE nurse who was doing the exam and all that. And I just remember thinking to myself, like, is she ever gonna get over this? And the answer to that is no. But is she ever going to be able to do something productive with it? Absolutely, she could. But I just remember thinking at that point, I just remember going, oh my God, this girl's never going to be okay. And I mean, just her stories and just hearing her, just recounting the story to the nurse. And I was like, I can't do this. And it changed my trajectory. I left psych. I was like, I've told my boss that night, I'm like, I'm done. I was like, I'm done. I can't do this. And my boss was like, no, you got to do it. You're good. We need you here. And I was just like, no, done, gone, out. And then I went back eventually. I went back when I became a nurse. I did psych nursing, PRN, like for a little while, and enjoyed it. But I'm a treat 'em and street 'em kind of person. Like I like the ER. I like the ER. Like, let's get them patched up and either get them out or get them gone. And you don't get that in behavioral health. In behavioral health, it's sometimes a lot,
You can catch feelings.
Yeah, right? Yeah, like who wants that? Come on.
You rather catch COVID.
Right?
At least you get over that in a couple weeks.
Yeah, and still, and I remember seeing this girl years later. I ran into this girl years later at the hospital of all places. And she came up and gave me a hug, and I was like, "How are you doing? Are you doing okay?" And she's like, "Oh no, I'm a mess." And I was like, "Sorry to hear that." And she's like, I'm in a bad spot." She's like, "And I don't have the resources, and I don't. When I did have the resources, I didn't take advantage." And I was just like, "Just keep trying, just keep trying." That's all I could tell. And I just remember, like, even then, like feeling the same heartbreak I felt for her 10 years before. Now she was, I think she was like probably close to her 30s. And I was just like, "Oh, you're just breaking my heart." So, but one thing she said was, she goes, she goes, "I always remember you." She goes, "I remember you guys always made me feel safe and feel good." And I was like, "Yeah, I guess we did something." So, but
yeah, it's funny because we as nurses, especially in the ER, we see dozens of patients a day. And then over the years, you see hundreds, thousands, right? And then the patients, unless you have you see them multiple times, your patients see you once.
yeah.
And so they remember you, and you're not going to remember all the thousands of patients. I mean, hopefully you go to court, but they remember you. You were a moment in time at their crisis. I mean, they came to the ER because something was wrong. So you were a person to them that they're going to remember. So you have to remember that whatever you do is going to impact thousands of people. What you do is going to impact them.
Yeah. Yeah. Now, you mentioned a little bit about your background. Do you want to share a little bit with the audience about your background and how you kind of got into what you are doing now, and how it changed you and shaped you?
As far as the trafficking aspect?
Yeah.
Yeah. So for me, again, I grew up in the foster care system, was adopted into a family that adopted children just to get money from the state. And there was a lot of abuse that happened.
Wow.
So for me, seeing not only the foster care system and the flaws there, and then having the biological family that was not the greatest either, and seeing all the gang action growing up and living on the streets, being homeless at 15. I ran away from home. I was a runaway youth because the cops were coming over to the house all the time, and domestic violence complaints. And I was showing up at school with injuries. And so cops were like, "Well, you're either going to have to be an emancipated minor or you're going to have to go back into foster care." And at 15, I was like, I got to go. I mean, because I was in and out of psych homes. The first time I attempted suicide, I was 9 years old.
Oh my gosh.
So, I mean, if you think of like child sexual abuse, I mean, it happens. And then when you have all the other contributing factors to the ACE score elevating, I mean, it's rough. So 15 years old, run away. And
At what
I
age?
mean, you can't really support yourself at 15, so you have to do whatever you can to make money. So I went on Craigslist and looked up an ad for somebody who was offering a modeling career, and go, I can do that. I can make money. I'm a pretty young girl. And so ended up meeting with this couple at the mall. They got my birth certificate. They got all my info. They made a bunch of promises, took a lot of pictures, posted a lot of ads, and there was other girls that were staying at the house with them. And they used our school because I was still going to school at this time. And I was going to a private Christian school that the state was paying for. So I had to have somebody take me to and from. And nobody ever picked up on what was going on at the school. They just thought I was a punk, gothic, crazy child that I didn't fit in. Yeah. Right. So, but I ended up getting taken to and from different homes, working poker parties, working as a model, working as serving drinks at a bachelor party with other girls. Like they would send us to all these different events, and we would have to wear what they told us to or what they told us not to. And they would post our ads and respond to everything for us, and they would pick us up and take us to and from. We never got paid for it, but they said that they wouldn't. They threatened to kill my family, and I was like, okay, please put me out of my misery. Thank you. Like I was obviously I was a runaway, couch surfing, living with random people. You think that's going to bother me? Like I've been living on people's back porch furniture, like surviving. So for me, that didn't work. So they threatened to tell the pastor at the church and like Christian school so that I couldn't graduate if they knew what was going on, even though. And so I was 15-year-old thinking I'm doing something so terrible, but really looking back, I was a child. Like
Yeah.
I was a kid. I had no choice. It was bad at home. It was bad in the street. And that's why when that patient went, like I clicked with her and I actually shared with my story with her, and we kind of
Holy
bonded on
cow.
another level. And I still follow up on her progress. But so
Now,
for me,
how old were you when the abuse started
I mean,
at home?
I was 5 when I was brought into that family. I mean, it was as early as I can remember.
Wow.
There were 7 kids, and there was 2 specifically that were special needs as well. So they were drug babies as well, but they were 2 older brothers that were um, the main perpetrators. And then the family that took me in, they ended up getting divorced and each got remarried. And then the one married a pedophile, and him and his sons were, anytime I go over there for visitation, I mean, they were just horrible to me as well. And then if I stayed home, it was like we'd get locked in our rooms with, like, it was just bad abuse either way. So and for me, like the system never picked up on it. CPS would come and do home visits and they never picked up on it. But the people who were fostering, they told us not to say anything. Otherwise, we're going to have to go back and I'm going to end up like my mom in prison, or I'm going to end up living at my dad's clubhouse. And so we just never said anything.
Wow.
But, and then even like being a runaway youth, I mean, living out on the streets, like anytime like I had a health issue or they took me in to go get like birth control or an antibiotic if I got sick, they'd take me into clinics or into an urgent care. And none of the medical staff ever noticed that. I mean, it was different people bringing me in each time, but if I mean, I was tiny. I was malnourished. Like I was a tiny young blonde girl being brought in by 2 Arabic older men. Like that doesn't
That
fit.
didn't
Like
that didn't raise a
what
red
was
flag? I mean, holy cow.
right. Like so that's why I do a lot of education to ERs. I travel all over speaking to doctors, nurses, residents on signs to look for in the ER, red flags, and delivering it in a way of, you're not doing anything wrong, but here's what you could do better. Here's things that were missed in my case, and here are proper ways to ask the questions to build rapport with patients, because we see it all the time. I mean, 80% of patients who are being trafficked end up in the ER, so they're just being missed. And I mean, I was missed, so I get it. So my goal in doing all the educating is to make sure that people understand not only what to ask, because a screening tool isn't going to do anything. They'll answer no to everything. It's how you ask it and how you come to their level and build rapport. So that's been a passion of mine, is just educating on what you missed. And I educate law enforcement and CPS as well on here's what you can do better and how.
Yeah. Now, how old were you when you got out of that lifestyle, and how did you get out of that lifestyle?
So I graduated at 17, and I went, so even that first year afterwards, I was still kind of, I mean, I was into motorcycles and street racing, and I mean, I was still homeless. I was living with whoever would house me at the time. I was surviving. But I was kind of on the run for a while. I borrowed somebody's car and I would like drive across the country and constantly being followed, and like always worried that they were going to find me. And then finally I went away to a private college in the middle of Wisconsin for a year, Baptist Bible College. And then I ended up having to leave there early. And then so I ran back to a city close, like right outside of Detroit, and I got married to a random person that I met online, changed my last name, and I lived out in the country with this new family. And
Like someone you knew well, or like someone you
somebody I met
like
online that
like
offered me like to get me out of it all, and yeah, it wasn't anybody I knew.
holy cow.
So I got married and I started over, and that ended up being not a good situation, clearly. It was through MySpace. But I ended up, so during that time, I mean, there was a lot of abuse and a lot of bad stuff that happened during that time, but it was different than what I had already experienced. And in my mind, I was like, okay, I've been through worse. I can endure this, keep enduring. I can do this. And I was going into nursing school at that time.
Wow.
So I was going to nursing school. I was working 3 jobs. And I was just destined to just move forward and to just get through it. And so I made it through that. I mean, with what I had seen growing up, like that was nothing for me. And I wanted to finish my nursing career and be able to make something of myself. And I did.
Good for you. Holy cow. Holy cow. And how is that transition getting out of that lifestyle, which, probably, I would imagine, it's easy money when you get into like, when you start working, it's not as easy money. Was it hard to go from that lifestyle, that more kind of instant gratification, like surviving lifestyle, to like go back to like what we would consider a normal life?
Yeah, so it's an interesting question because there are different levels. When you talk about being trafficked, or I would call it commercial sexual exploitation. There's different types of trafficking, but with sex trafficking in particular, I mean, there are times that you have a girl, like a pimp has girls working for him, or a family takes in other young girls in their stable and they kind of run their dates for him, set them out. And the victim doesn't get any money. They just get a place to live, taken care of, and that's it. But if you're a high-end escort, I mean, you can make $5,000 a night at
Holy
least. I
cow.
mean, you can make good money. So when I was transitioning from being like the whole going to nursing school, getting out of a marriage, trying to figure out what I'm going to do, that was always, so the high-end escort lifestyle, that was something that was very hard to stay away from. Because I mean, a nurse, you graduate, you make $50,000 a year starting, you can make that in a month if you're
Wow.
traveling around the world living a high life with somebody. And so that's when I had to really learn to love myself and gain self-worth back and go through all the work and I went through a lot of therapy, and I had to realize that it's just green paper at the end of the day. Yeah, it's a lifestyle, it's great, the money is great, but my self-worth and my value as a human and what I can give back to people is worth more than any of that. And so it was wanting to change lives, wanting to help people, and wanting to give back instead of the people who are in that lifestyle because of what they can get and how they can be taken care of. I always had the heart that I wanted to take care of people, and I couldn't do that by having somebody take care of me and be in that life. So for me, yeah, but that's definitely a struggle, especially with the girls that are in the life. I mean, we look at them as prostitutes or working girls, but I mean, really look at their childhood. I just see them as a hurting little girl that never got rescued, and they just don't know their worth. But a lot of times the girls are not prostitutes; they're being prostituted, and it's something that's being done to them, which is why even in the ER, I mean, we have bias a lot of times. Like they come in for abdominal pain and vaginal bleeding. We do the speculum exam, and like, oh, it's a completely normal exam, and now all they want is a sandwich. Well, maybe she hasn't eaten in 3 days, and maybe she just wanted to get away from her pimp for a while. So have a little sympathy, take some time, sit at the bedside and just talk to her. Ask her about her tattoos, be excited about them. Ask her where those names came from and who the artist was. Build rapport. But there's just a lot of skepticism and bias. Even in the years that I've been a nurse, I've seen it in the ER over and over. But I mean, a lot of strides have happened to shine light on the situation, but I mean, it's still there. It's still a problem. And that's why a lot of the care isn't the best, because there's just the stigma that they're choosing it or that they want to be doing it.
Mm-hmm. Holy cow. How do we not miss that in the emergency department? Like what do we need to look for? How do we make sure that if a young Rachel comes into the emergency department tomorrow, that Tina, who's listening to the podcast now, doesn't miss that? How do we make sure that they don't miss something?
Yeah, and so that's a loaded question, but I'm going to answer it as quickly as I can because I usually do like 60-minute in-services. But the long short is just be a nurse. Remember what you went into nursing for. It wasn't about how many patients you can see in a day. It's not about it. What it is about is caring for people. And if you truly care about someone, you take the time and you spend it with them. So many times as a nurse, we take our computers and we roll them in and out of the room, and we do the check off in their computer charting, because that's what it all is. It's virtual, right? How often do you actually sit down look at the patient, take notes maybe, but just take it all in, make eye contact, sit down at their level so you're not standing over them. When's the last time you sat down in your patient's room? Being present is key to any patient in general, but especially when you're a victim of trafficking, whether it's labor or sex trafficking or domestic violence, like sexual assault. These are psychological traumas. And to be trauma informed, you have to understand that if they're looking away when you're trying to make eye contact with them, I mean, that could be red flag. They're looking away or always looking at somebody else in the room, making eye contact with somebody else. Well, first question, why is there somebody else in the room? We're supposed to separate our patient when getting a history. We're supposed to have that one-on-one unless they request advocacy. You're supposed to give them that privacy because you don't know who's in the room with them. You don't know if their brother that's there is actually their pimp, or if their sister that's there is actually their wifey in the life. You don't know who that is. That their coyote? Who is that? You don't know. So giving the patient the opportunity to be alone is key, because I was never separated from anybody. I was always with somebody. Somebody was answering questions for me, filling out forms for me. The only emergency contact I ever had was them. So, and then, so it's those simple things. And then just listening, taking time to listen. I mean, as an ER nurse, I will say as an ER nurse, it's difficult to have your ER nurse hat on as well as the sane nurse hat on. Those are two very different roles.
Yeah,
I was both for a while. And then, I mean, if your hospital doesn't have it, you don't have a choice, but it's very difficult. And I will say that if you don't have that in your program, it's difficult. Getting a community-based sane program or having working collaboratively with hospitals that do have it to be able to have staff on call to come to you is the best thing for the patients. But hospitals have so many politics. They don't like to band together like that. But I mean, when patients come in with that type of trauma, you need a specialized nurse who can provide that specialized care and take the time that needs to listen to the whole story, find out more, offer resources, know what resources to even offer.
Absolutely.
Because if you get a whole bunch of information from them and you don't know what to do with it, then you just get there with your mouth open and there's nothing you can do. So
we were really lucky in New Mexico. When I was in New Mexico had a pretty solid sane program where it was, there was a team that worked together, and they went to all the hospitals. They didn't work for any of the hospitals. They weren't affiliated with any of the hospitals. They were their own entity. And they would either come if they were unstable enough that they couldn't come to that we couldn't send them to them. That was their preference, that we'd send them to their place. And they were like, put on a cab, we'll take care of it. Everything's good. We'll take it from here. But if they were so sick that they had to come to the hospital, then they would come to the hospital and they would assume care of those patients and really give them the time dedicated that maybe the ER nurse wouldn't be able to do. And it was a great program. They really did such great work. But I know it's not like that everywhere.
Yeah. And even in the ER, when you get a sexual assault patient to your room, a lot of times that's what they're going to come in for. And then you find out, okay, there's strangulation involved, there's human trafficking involved. So that's like 2, 4, 6 hours for that patient that you really have to give them competent care. And as an ER nurse, you have 2 codes going on, a septic patient, and then you have this one in Bay 4, and you're like, oh, I don't have time. So then they just sit there. And when you come in with that kind of trauma and you're hoping somebody has the time to talk to you, but they don't, you're just going to not disclose. You're going to leave before registration even finishes. It's just, the ER is not conducive for that type of trauma if you're not adequately staffed. And that's ultimately the problem. But
how often do we find that when people are kind of rescued from this lifestyle or kind of brought from this lifestyle, how often do we find that they had presented for medical care, or they had presented to an ED and maybe it wasn't picked up?
Yeah, most studies say about 80%, 87%, but it's at least 80% have come into the emergency room within the last 6 months of being exploited. Yeah. And a lot of the reasons given are that they use somebody at the bedside to translate for them. So never do that. I know it's quick and easy, but don't ever do that, especially with labor trafficking. But with anyone, don't use a family member to translate. And then they never separated somebody, asked them to leave the room, so they're never one-on-one. But a lot of times the victims, they don't self-identify. I didn't even know what human trafficking was until I studied in forensics and found out there was a definition. I always thought that I was doing something wrong and I was afraid to tell anybody. I didn't even put it in my book. I was so scared. I'm like, I'm going to go to jail for this. Like, what did I do wrong? But once I actually understood, oh, there's a term for it, it was something done to me, and it totally reshaped my mindset. And that's when I actually came out and started speaking about it, because when you're in the life where you're being trafficked, you don't know what trafficking is. You just think that you're hustling, you're making money, you're in the game, you're making your bread. You don't think of it as somebody's committing a crime against you. And so that misinformation needs to be acknowledged, like, right from the beginning, so that they're not scared that they're going to catch a case, that they're going to go to jail. You have to acknowledge the elephant in the room. If they're non-English speaking and they fear deportation, I mean, letting them know there's T visas, U visas, we have options for you. Like, whatever, you're safe here while you're with us. Let us know how we can help. And a lot of times they have to go back to the life. They have children. They have sometimes animals, whatever it is, a drug addiction. That's a big one that's not identified, but they have reasons that they have to go back. So rescue to us as an ER nurses, doing a correct compression to breath ratio, saving a life, that's a rescue to us. So we want that instant gratification of they were dying, I saved them.
Yep.
But with trafficking victims, rescue is sometimes just showing them that there's a light at the end of the tunnel. That means giving them a hotline number to call when they're ready, giving them a shelter they can go to when they're able, because they might not ever come into your ER again. They usually go to different ones and they spread it out so they don't get caught. So rescue isn't calling the police and saving them. You can actually do more harm than good. If it's a child, it's a totally different story. It's a mandated report. But if it's an adult, rescue isn't getting them out away from their pimp that day. It's letting them know that you see them, you hear them, even if they're not talking. And when they're ready, you're there for them.
Wow. Oh, that's powerful. Holy cow.
It's heavy.
It's heavy. Holy smokes. And it's crazy because I could see, I always tell people that I was always when I was working as a nurse and working, a busy emergency department, I always said I was like the master of drive-by nursing. Like, I'd just drive by and be like, pulling, hey, you doing okay? Yep, you're still breathing. That's good. Okay, let's go. Go to the next room. Go to the next room. Hey, you doing okay? Oh, yep. Okay. Pain meds. Gotcha. Be right back. Go to the next room. Hey, you doing okay? And sometimes I didn't get a chance to take the time to sit down and talk to my patients. And when I was a little bit more of an experienced nurse and realized more what to me was important, like, being in the big bad trauma that's, big bloody mess wasn't to me as interesting as sitting at a bedside and just having a conversation with the patient. And I remember a couple times I'd be working a casual pool. I was working as a director in the emergency department, which is a super thankless job. And then I would work one day a week in the trauma center and go be a nurse. And they'd be like, well, yeah, okay, we're not going to have you go do traumas because might be a little out of practice. We're going to have you be in the cubes, or we're going to have you be in the alcohol intake area. And I'd be like, psh, great. I can take good care of those people. But the nurses would always laugh when I'd just kind of pull up a stool and just sit down and talk to the patient while I was doing my assessment. And I'd just sit down and talk to them, maybe do a little typing, be like, okay, hold on one second. I got to type or I'm going to forget all of this. I'd type for a little bit and I'd turn back and just, kind of sit and just kind of look at him and be like, hey, what, tell me what else and what else is going on, and sit and get to their eye level and just have a conversation. And the big difference there, I always say that the big difference is there's a big difference in taking care of somebody and making them feel cared for. And if you can do both, by golly, they are never going to forget you. So, and that's a good thing to do. Especially for such a vulnerable population. For such a vulnerable population like we see in like peds, or we see, these people who are at risk and at risk for human trafficking.
Yeah. And a lot of times we don't take the time because we feel like we don't have time, when if you actually sit down and think about it, all the patients that you saw, all the tests that were ordered, and all the patients who sat for 8 to 12 hours in the ER because they needed a CAT scan and then they needed an MRI and started with an ultrasound. Well, if you would have taken the time at the beginning to ask the right questions and to listen more, they would have told you, well, it radiates from the right to the front, or they would have told you more to get the right test right away, so you didn't go through all these loopholes because you didn't listen well enough the first time. If you take enough time with each patient from the beginning, it's going to take off time at the back end, and they're going to be in and out sooner because you're going to do it better. And so then you'll have more time for everyone there.
Yeah. That's absolutely true. Now you mentioned now that you do forensics, you're doing ER nursing, you're doing some education and speaking. What what kind of education and speaking are you doing? And are you out speaking about your experience, your human trafficking, and you mentioned you were teaching law enforcement. Tell us a little bit about that.
Yeah, so I go to ERs, and I train ER staff, social workers, residents, doctors. Whether it's a 30-minute or 60-minute in session, I train as many people as I can. Um, Healthcare specifically on signs and symptoms to look for, red flags, and the what's next after identification. Law enforcement, I've trained at the FBI National Academy, HPD, District Attorney's Office, different conferences, the conferences on crimes against women, crimes against children, just all over the country, different law enforcement agencies on what to do on a DV case or when it's sexual assault and how to ask the right questions so that you know when you need to take them to the hospital or not. Because a lot of times law enforcement will go to the scene and they'll arrest a juvenile for prostitution, 16-year-old, and they'll put him in juvie or they'll take them to a facility, but they don't take them to the hospital. So reframing law enforcement's mindset on health first, and you're going to make your investigation a lot easier, because anything that's said to a nurse in the history that's used for medical diagnosis and treatment, which is their history to us, anything they tell us, we can repeat back in court under the medical exemption to hearsay. And social workers can't do that. The police officer can't do that. So if you don't have a victim, if they die or they can't talk, you can talk as the nurse on behalf of them. So what they say to you is so important. So letting law enforcement understand that when you pick up a victim, before you book them, bring them to the ER. We have 72 hours to give them HIV prophylaxis. You have Plan B, you have time-sensitive medications. And so when you bring them to us and say, we're going to medicate you for sexually transmitted diseases, make sure everything's okay. When you present it like that, the nurse is going to do a lot better job than a law enforcement agency is on talking about health and wellness. That's just a known fact. And any officer I've ever met will admit that. So letting us be a part of that helps not only on the front end for their health, but when it goes to court, we can help with that process as well. And then law enforcement, their investigation is going to go a lot smoother and save them time, because we're going to give them a report and they're going to have so much more information on what actually happened, because they're going to trust the nurses in the ER, and we're going to get a lot more than the police officer ever will. So I educate them on that. And then Texas DFPS, just educating them on the foster care system, how to improve that, signs and symptoms of like what you missed and how you can do that better, how to improve the system. It's not an overnight process, but at least they want to try. Our governor's office wants to do so much. They have so many coalitions and task force that's helping, and they're even bringing survivors in to review policies and protocols to actually do it better, which is awesome. So great progress. And then educating on strangulation as well, because it's something that goes hand in hand with human trafficking a lot, and it's missed. The gold standard is a CT angiogram, and they're not being done, and then patients are being strangled and having strokes days, weeks, months later, and a lot of neurological side effects because people don't know and understand the lethality of one strangulation episode. So those are some of the things that I train on when I go.
Holy cow.
And then building in, so I'm able to speak to those audiences because I've done some undercover work with law enforcement.
Tell us about that. Like what was that about?
So in Detroit, started in Detroit and then brought that down to Houston. But just so people always ask, why don't they just shut down these brothels? Why don't they go in the massage parlor, shut them down? Why don't they rescue the girls or shut down the hotels? Well, because in jurisdictions you have law and order, you need warrants. You need PC. A law enforcement officer can't do a lot of things that we would think is so simple. So as a civilian, for me, I have no family. I have nothing to lose. So I do a lot of high risk taking behaviors, which is why I've gone all over the world. I've done rescue operations. I've pulled victims out of pretty dark places.
Holy cow.
And I go out in the track and the blade, and I do a lot of outreach and intervention, and done hotel ops and back page things and John ops, and worked with law enforcement on baiting and getting the Johns there to the scene. And again, my motto is from the street for the street. So I used what I know from my experiences in the life and from just my family and everything I've experienced and seeing it to give back and to be able to help law enforcement because they have read about it in books, they've been trained on it, but they didn't live it. So the lived experience
Different.
is key. Yeah. And so for law enforcement to listen to the voice of a survivor or somebody who's been in the life, it's like taking a gang member out and saying, hey, tell us all your secrets. It's kind of the same principle. Here's how you can do your job better. So that's something that I have done. I don't recommend that for anybody listening that's untrained. I mean, it's very dangerous. I usually have my Glock with me, and I've had some training, so it's definitely not for everyone. But as a civilian, I can go in somewhere, I can take pictures, I can go ride around in a jet with somebody who's taking girls to Aspen and give a file back on the desk Monday morning. But a law enforcement officer couldn't. So those are the kind of things I do. Just get intel and do as much for the one to save one at a time. And then on the broader scale, the more you educate, the more I can give my knowledge to a greater audience. So I don't do as much of the undercover anymore. I do more education because I'm only one person. Yeah. And so being able to educate and have it on a bigger platform, I can save a lot more.
In the forensic area and in your activist kind of arena, what's been your biggest win?
My biggest win, probably getting, I mean, in Houston specifically and in Texas, there's been a lot of breakthrough because a lot of the organizations, there's a ton of organizations for anti-trafficking. But
I've heard trafficking is like a big deal here.
Oh, it's huge here because we are proximity to the border and we're a port city, and you have a lot of men with money here, and the demand is the men. So the demand side, if you can lower that and educate the demand, I would hope that 100 men who paid for sex last night or went to strip clubs thinking that these girls wanted it or that the girl chose to place her own ads, I would hope that 100 of them, if they knew the true story of the girl behind the scenes, that at least half of them wouldn't do it. They just don't know. So the demand side is key on if we end that, because we can rescue girls all day. They're just going to go get more. But Houston, we have a lot of oil and gas, healthcare, big industries where a lot of men work, and where you have a lot of demand, there's a lot of supply being brought in. I mean, girls are trailered in here. They get brought in by the busloads and they get moved around to different cities. And so, yeah, Houston is a big deal for that. I helped with the Super Bowl when that came into town, and we HPD made a ton of arrests. HCSO did, and there was a lot that happened. Just anytime there's a major event, the girls get brought to that city for that event. So that's one of the reasons Houston's known for it here. Wow. But we're also, our city has, in the last 5 years, I've just watched it transform. Working with the vice unit and with the mayor's office, the governor's office, the Houston CHI, St. Luke started a healthcare coalition that all the hospitals meet at the table and say, what are you doing for your hospital systems? Can we all work together? And the Houston 20, the Houston Area Against Trafficking, just all these organizations starting to come together and saying, hey, we're not competing. Let's collaborate. How can we share services? So that's been really huge, just being able to be a part of that and kind of, because now I consult with a lot of organizations to try to make it work better. So how can we all be at this table together and bringing more survivors' voices? So that was my main goal this past year, was to bring more survivors to the table and be able to look at all these organizations that want to help survivors. Do you have any on your board? Do you have any consulting? Have they looked at your policies and procedures? Have they told you what best practices are in the hospital? No? Oh, well, then why don't you ask some? So being able to empower survivors and bringing Survivor Task Force into play has been the biggest success of the year, because now they're not only getting organizations trauma informed, but survivor informed. And even the governor's office has started a survivor work group. So that's been great.
That's super cool. Holy cow. Wow. What a huge potential impact.
Yeah.
That's awesome. Holy cow. Wow. That's heavy.
A lot.
That's a lot. Wow. Here you are just smiling, going, yep, just making a difference.
Just day in the life.
Doing some pretty cool stuff. That's pretty cool.
Yeah, but I mean, as a nurse, as a healthcare, in the ER specifically, 80%, at least 80% of these victims are coming to the ER. They're not going to social services. They're not going to these nonprofits. They're not going to law enforcement. They're coming to you. So you, out of everyone in the world, as a healthcare provider, as an ER nurse, you have more of an opportunity to save trafficking victims than any other organization, any law enforcement, any state agency. You do, because they're coming for healthcare to the ER because it's in and out quick. They're coming to you. You are the ones who are able to save more than anybody else can.
Wow.
So it's key to have the proper education and the know-how and what to do next.
Very cool. And is there education available for nurses, or where can nurses learn more about recognizing trafficking or sexual trafficking?
Yeah, so there's a lot. So there's HEAL, there's SOAR, SOAR, and then HEAL, HEAL trafficking. Those are great sites. In Houston, we have the PATH Collaborative that's going to be launching soon, and we're going to be educating healthcare systems. We're going to be going around to different hospitals, probably starting with San Jose Clinic, then going Ben Taub and CHI, but we're going to be educating. So that's coming up in the next few months. We're going to be launching those.
And what's that called? That group called?
The PATH Collaborative, PATH. And so Kimberly Williams from CHI, she's been heading up the Human Trafficking Healthcare Consortium, where all the leaders of all the major hospitals meet monthly to discuss the issue of trafficking. And they do monthly, that's open. You can sign up through Eventbrite. But I mean, there's so many resources, so many webinars, so much education available. Rescue America, they have the exit hotline. That if a patient is ready to leave, they'll go to the hospital, pick them up, get them triaged and placed. And that's a huge thing that we have here. Rescue Houston was the first one to be able to launch that. So there's so many patient resources, but the nurses just don't know. A lot of the hospitals in the ERs have been putting it on the discharge papers. But there's also legislation that was passed that says that every emergency room has to have side by side in every single patient exam room and every single bathroom, one in English and one in Spanish. It's HB 2522 says it has to say it's illegal to force someone to have sex for money, and it's illegal to force someone to have an abortion. In English and in Spanish, side by side. It's legislated, but not a lot of the hospitals even know that it's in there because it's hidden in the human trafficking section of the legislation, but it's specific to emergency rooms, and a lot don't know. But we had, even after launching one hospital, we had 15 people call the first month for exits.
Wow.
Just after having the posters up. So if you can imagine, I mean, and the numbers have even grown. So if you can imagine, if every hospital was compliant with legislation and having those placards in each bathroom and exam room, the exits and the life saves would be like exponential.
That's awesome. Part of what I wanted to do here with this podcast is share this information, because so many ER nurses just don't know. They just don't know.
Yeah.
So.
Yeah. And that's what I always say after I give a presentation. Everybody's like, oh, I had that one patient. Oh, and I'm like, yeah, you had a lot of patients, but don't think back on the ones that you missed. Because if you were untrained in CPR, you could kill somebody giving CPR wrong.
Think of the next one you're going to catch.
But now that you've been trained, now you can properly save a life. You know how to do it well. Yeah. Because the patient is always going to know what's their best safety plan for them. Regardless of your knowledge, they will know what's best for them. So it's learning how to listen and how to work with them on the best safety plan. But so it's not about what you missed, it's how you can move forward and help people.
Absolutely. So the last question I always ask my guests, and I'm going to ask you, is what are 3 things an ER nurse should always remember? What are 3 things they could just go ahead and forget?
3 things an ER nurse should always remember. I would say that you can't control the patient outcome. You can't control their health and their body and what their body does, but you can control the care that you give them. You can control what you do for them. God
damn, that's so good. That's really, really good.
You can't control whether they live or die. You just can't.
Yeah.
And then remember, it's at any given time, it's all about the patient in front of you. Regardless of how many patients you have, regardless of how much you've done or you plan to do, it's always about the patient in front of you right now. Nothing else matters except for that moment, the patient in front of you at all times, every time. Remember to know remember that you don't know what you don't know. And so to know your resources and to not be afraid to ask. Because that's one thing we get macho. We're like, oh, we're your nurses, we know everything, but you don't. And so you have to remember that because you don't know everything. So you can't be afraid to ask for help when you need it.
Absolutely.
And swallow the humble pill. 3 things not to forget.
3 things to forget.
3 things to forget. Forget everything you heard on TV. We're not living in Grey's Anatomy. It's not like the show. Forget.
No, nothing like the show.
Yeah, no. And forget your ego at the door when you have a new nurse that you're precepting, because you were a new nurse once, and it's really irritating to have to show somebody what you're doing every time. But you have to remember that you were a new nurse too. And a lot of nurses get burnt out because their preceptors are mean to them or get frustrated with them. So you've got to let that ego go and just raise up these baby nurses.
Absolutely.
They're going to be taking care of your parents someday. So train them well.
Right? Ain't that the truth? And one last thing to forget. I told you this part was hard.
One last thing to forget. Forget that people told you that doctors go to school a lot longer than nurses, so they're smarter than you. Forget that, because a lot of times I love my doctors. I love them all, but I have saved more doctors' licenses than I can even count on.
Absolutely.
On my hands. I mean, you are a key aspect of the team, the multidisciplinary team, and they have a lot of patients. They're seeing a whole ER of patients, and you're seeing your 4 or 5, 12 patients. But you have to double check everything. So don't trust everything they say and just do it. Make sure you double check everything, and you are that second check. It's you that's going to be pushing that medication. It's you that's going to be setting the jewels. It's you that's going to be acting out on what the doctor tells you to do. So don't think that they've had more school than they know, because a lot of times they're residents and they don't know, and you're actually educating them, and that's fun. I love educating all the residents.
Absolutely.
But yeah, never forget that it's still you who's gonna be the one answering for it if you make a mistake.
Amen. Ain't that the truth? So I think that's all the questions I have for you. I appreciate you spending time with me, telling me the stories, and oh my gosh, and I think you're an amazing woman. Holy cow, how lucky we are to have you as a nurse and doing the things you do. So I can't thank you enough for that.
Thanks for having me.
If you're interested in hearing more about Rachel, her book is available right now on Amazon. I'm going to leave a link to the book in the show notes below. Take a look there and you'll find out how to find her book and hear more about her stories. Until then, Rachel, please be careful out there. And the rest of you, have a good shift.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.